Just looking at the list of attendees in terms of work group members, I'm seeing that Jeff Brown, JJ, Sean, and Tom Siltebeau are in attendance. Are there any other innovation workgroup members in attendance that I missed? Okay, hearing none, that does give us a quorum so that we are able to take action. And the first agenda item up on today's meeting is the call to order and approval of synopsis from the October 20th meeting.
Okay, I will call to order the January 19th, 2021 meeting of the Innovation Workgroup. Has everybody had a chance to look at the minutes from the last meeting? And if so, can I have a motion?
This is JJ. I move to approve the last minutes.
This is Sean. I'll second.
Okay. Since that already constitutes a majority, I've been made aware that there is a Robert's Rule of Order opportunity to say assumed passage and then ask, are there any objections? So be it. You can slap my hand later if that's inappropriate, Margaret. Before we go any further, I wanted to introduce Tom Siltebeau. I think many of you may know him. I've asked him to join our meetings as a non-voting member. His experience as a physician and the number of organizations that he has participated with, I think will prove valuable in giving us some additional insight. Tom, did you want to say anything?
I've been following along the IWG since its inception, chairing the CIO group with OAB. You know, we get into the weeds while you all get to talk about the grand design. So I'm thrilled to be able to listen in and participate however I can. My background includes that of a family physician. I also was chief of staff of a hospital. I was a medical director for primary care services within Kaiser Permanente. And my last 5 years, I was the physician representative to the health plan. So learned something about the insurance business too. So I'm, as most family doctors, I'm, the master of none, but know nothing about everything. So I'll help out however I can.
Thanks, Tom, and welcome.
Thank you.
Appreciate your commitments. Next up on our agenda is the legislative update. Ali and Glenn.
Yeah, I can get us kicked off here, Glenn. And I would just add that I'm tickled to have Tom around. So that's great news. Glenn has a much more detailed legislative bill report. The only thing I really have for the group is we'll be up for our Ways and Means presentation on Tuesday, February 9th. That's a tentative date, and we've been working with leadership of both boards to finalize the presentation, and it's getting closer to being ready, and we'll pass along that presentation as soon as it's been presented and fill you in on any questions that were asked. So, you want to take it away, Glenn?
Sure. Basically, let me just start off with, for this session, the link for the session is January 19th through June 27th. Unless they vote to extend, they usually try not to do that, but sometimes they do. They're still working on whether this will be a probably a mixture of remote and on-site hearings and meetings, but they're still finalizing that. In regards to legislation, there was a large amount of bills that came out in the beginning of the session. We've gone through those bills, and what we've done so far is we've prioritized them. Priority one is the ones where these would be bills that have actually a direct impact on PEB and OEB. They create a new program or new policy, or just new responsibility for PEB and OEB. Twos, we have usually they're somehow have a financial impact on us, say through a new benefit. And then threes, fours, and fives, those are usually ones we're just watching because they may have a relating clause, say healthcare, that could affect us down the line. They may change the content, and then it will affect us. And so I wanted to go just over the priority one bills and kind of give you just a summary of them, and then answer any questions about that. We're still analyzing a lot of these bills, so we don't have all the details. The first one, Senate Bill 551. This is actually a bill that we've seen in the last 2 or 3 sessions. It's changing our the OEB's current HB 2557 program, which allows part-time faculty at colleges and universities who are PERS eligible to participate and select OEB plans at a self-pay basis. What this does is it changes it to where the state will pay 90% of those premiums and the member will pay 10%. We've had a number of discussions with the legislators who are kind of behind this bill, and we'll be working through that. It really has primarily the largest impact is actually on the state itself through general funds for these insurance payments. Senate Bill 12 is a new bill that is basically calling for PEB and OEB to create what's called a pharmacy tourism program, which this is a program that's being done by more employers, but not really a lot of employers. And the only state I know I could find that it does it is Utah. Basically what it does is it says that for select, usually specialty medications, that in this case, PEB and OEB would pay the airfare, coordinate travel, actually pay the prescription costs if people actually went to select pharmacies in this case, Tijuana and in Vancouver. Of course, there's a number of questions in regards to what would be the actual administrative cost, what would be the impact on our current, costs, as well as some legal concerns, because it's not totally clear about what the FDA rules are on that. Senate Bill 650, that's actually kind of a one where I would say it's probably a drafting error on behalf of the bill advocates, and what it was, it creates what's called a public assistance protection fund. This is a fund where employers who have employees of over 100 employees, would pay a certain amount into this public assistance fund, pay for things such as, OHP, other public programs, and it says that 25% of that money would go to PEB to offset school districts for unfunded pension liability. That either could, I guess, mean OEB, or what they're maybe actually talking about would be go to PERS. House Bill 2317 adds 2 non-voting legislative members to the OEB board, making it, of course, pretty much the same as the PEB board. The last bill, House Bill 2810. This is a bill that really, what it does is it requires that all of PEB and OEB's ASOs, carriers who offer medical plans have to offer an option that is CCO-like and has things such as global budgeting, risk sharing, gets rid of the requirement of or the ability for PEB and OEB to use hospital reimbursement caps, a number of factors and criteria it has for these types of options. From a timing standpoint, it wants this to be done starting in 2023 for PEB and OEB, and then for one option, so they would have to offer at least one option, and then 2026, they would have to offer their only options would be these types of plans. There's also some other elements too. It would change how quality is assessed, and it would require what's called the Metrics and Scoring Committee to set quality measures for PEB and OEB. PEB and OEB currently use the quality measures that come from the Health Plan Quality Metrics Committee. It also requires that we set up a 5-star rating program for all of these medical plans. So it's pretty complex, and it has a lot of, I would say, moving parts to it. And so we're trying to do some more analysis and really kind of get some more information on this bill. Those are only priority 1 bills. We also have 28 priority 2 through 3 bills. Are there any questions, any more information? I can certainly send you copies of these bills if you want.
And are there any big bill drops coming up, or do you think we have the majority of them dropped?
Rumor has it there's going to be another 1,000 this week, but that hasn't been proven out.
Okay. Looks like JJ has a question. I kind of jumped the line there. Sorry.
Yeah, you mentioned that there are a couple of non-voting members of the legislature on the PEB board. Do they regularly attend the meetings?
Well, it depends. I know right now, and Ali, correct me if I'm wrong, Representative Salinas on the PEB board does try and attend as much as possible, but
she's there pretty consistently. But Senator Johnson, we haven't seen her for a couple of years.
The reason I ask is we have 2 non-voting legislative members on this committee, and I value their attendance when they're here, but it's pretty sporadic and pretty rare. And so the value that they add is pretty minimal because they're not here. And so, I mean, if the legislature wants to add people to the OEB board, I welcome it. I think it's a great addition, but only if they're going to show up.
So I think what is putting some physicals together on these and keep the innovation work group and both boards up to date for leadership. There's a couple pretty ugly ones here, and we'll definitely require some physical work being done. But So far, Glenn's kept up, and kudos to him. It's unbelievable amount of work that kind of just gets dumped on y'all at once, and you're not sure when the next pile is going to get dumped. So
thanks, Ollie. And yeah, I would just say that, you know, right now we're being asked to do what's called the bill analysis themselves, which are really analysis for the internal audience here at OHA. And then we'll probably get asked more for fiscals, which come from really through OHA, but through the Legislative Fiscal Office. And, you know, right now in regards to timing, they have till about mid-March to move these bills out to policy committees, unless they go to Ways and Means or Rules. So, you know, we do have some time, but, you know, yeah, they can be kind of quick in regards to their requests sometimes.
All right. Well, thank you, Glenn and Ali, for those updates. If there are no other questions or comments on the legislative update, we can move on to our next agenda topic. And that topic is related to the Centers of Excellence RFI. Willis Towers Watson is going to present some information related to this body of work, which is something they undertook late last year at the Innovation Workgroup's request. So I believe Jenny Marks is going to kick us off from Willis Towers Watson, and so I will hand it over to her.
Thanks, Margaret. Yes. So I'll go ahead and get us kicked off. I did pop on just to say hello, but my computer is telling me that my bandwidth or something is unstable. So when we get going, I think I'll pop off just in case. I don't want to lose you all during this. So yes, we're going to be talking about Centers of Excellence, and this is what we've been talking about in some way, shape, or form over the past year and a half. So we'll kind of go over, you know, what's the RFI and what do we do. I do have on the line with me Dr. Lewis Dickey, who is one of our consulting physicians. And Dr. Dickey has quite a bit of experience with Centers of Excellence, and as well some experience with medical carriers, and then has worked with us on a variety of other topics in support of the Innovation Workgroup. So let's see, before I get going, Dr. Dickey, do you want to just give like a 2-minute background of who you are and what your experience is?
Sure. Thanks, Jenny. Lewis Dickey, Medical Director at Willis Towers Watson, and I'm in our Dallas office. Have been working with the IWG for, gosh, it's been a couple of years, I think, by now, on a variety of topics, and started out at the beginning with our MSK and cancer discussion, which has culminated in a couple different initiatives, including the Center of Excellence, and have been working very closely with Jenny on that, and have done similar type consulting work across other clients within the Willis Towers Watson portfolio of clients. And appreciate the opportunity to be here to talk to you today.
Okay, so again, we've been talking about Centers of Excellence for a little while now. This work really started in 2019 when the Innovation Workgroup, Mercer and Willis Towers Watson took a look at, you know, what are the big cost drivers in the OEB and PEB plans. And then once we took a look at that, there was a lot of discussion about what are some of the possible things that you can do about those cost drivers. And one of the things that, and we'll get into this a little bit in the presentation, but so, you know, a big area of spend is in musculoskeletal. And one of the things you can do is to explore Centers of Excellence strategy. And again, I'll talk about this in a couple of slides, but So, we were talking about this before the pandemic, then we took a little bit of break and then sort of brought the idea back and started exploring this idea again in the fall of 2020. And then that really led us to let's just do a request for information about what can some vendors who specialize in putting together centers of excellence, what can they do and how do they add value? And, how does that compare with what, the carriers could or would be able to do in this area? And so that's what we're going to be going through with you today. I'll do a very brief executive summary about what we found, and then we'll go into the detail, spend a very short amount of time doing some background about, again, why were we taking a look at this and what is the centers of excellence and what are the best practices. We'll talk a little bit about the approach that we took to this particular request for information, and then I'll go into the summary of responses. And then in the next steps, these are really potential next steps about, and this will be hopefully a nice discussion about what are the things you might want to do with this information going forward. Okay, so executive summary. Essentially, if you put together a center of excellence, the purpose of it is to drive volume and increase quality for those particular procedures. We did focus on this RFI and musculoskeletal procedures, which is a key cost driver for OEB and PEB. There are specialty vendors in the marketplace that have a lot of experience establishing what you need, taking a look at what you need to look at in order to come up with a center of excellence. So the quality metrics and the reimbursement methods. But of those that we asked about, not very many of them have a lot of experience in the Oregon healthcare market specifically. Conversely, we also asked OEB and PEB's current medical carrier partners to respond to the RFI, and they, of course, have a lot of experience working with OEB and PEB, and they have a lot of experience working here in the Oregon marketplace, but they tend to focus more on supporting their own unique, more broad preferred networks. And then at the end here, you can see that there's going to be some opportunity to see how we can kind of merge those two ideas. Okay, let's go ahead and go forward. All right. I shared a few of these stats before with you and just setting up the business case for why would you take a look at musculoskeletal conditions and centers of excellence for those. And I mean, at the end of the day, things like knee and hip replacements, and in many cases back and spine procedures, there's a fair amount of variation and preference sensitive nature to those procedures. Not all the time, but there is, it's definitely there. There's also variation in cost for the procedures based on, where it's happening and the cost and the reimbursement for the particular hospital. So because of that, there's an opportunity to say, should we try to drive a lot of volume into one or two facilities that really excel in this area, and that turns into better outcomes. Let's go ahead and go to the next slide. Okay, and this is another kind of repeat slide that we shared with you before, and the purpose of this slide is to remind you that just focusing on the centers of excellence is just one pillar of a sort of a three-pronged stool, if you will, in approaching musculoskeletal conditions. So you need to take care of the prevention and provide wellness and proactive health support to members, weight management, that kind of thing. The middle pillar has to do with steerage, or giving members information early on about the conservative therapies and physical therapy support so that it doesn't get to a point where they need surgery. But of course, there are a few, there are times when surgery is appropriate. And so, if you're going down a center of excellence approach, it's trying to drive those to the right hospitals and facilities. Okay, let's go ahead and go forward. Okay, I think I was going to have Louis, you kind of cover a couple of these slides.
Yeah, thanks, Jenny. And we have been talking about centers of excellence for a while. And since it has been a while and there's been a lot that's happened since then, thought it would be helpful just to revisit, what are we trying to accomplish with the Center of Excellence strategy? So we listed these talking points at the top. First one is really diverting unnecessary surgery to more conservative therapies first. And the literature is pretty clear that to the extent that the member's care for back pain especially isn't following evidence-based guidelines of 4 weeks or so of conservative management in the absence of any red flags, and that they're not imaged until after they've completed conservative therapy, those individuals can end up with a much higher rate of surgery and may or may not have a better outcome. I don't know about you, but okay, yeah, now I can see it. The second is that you're really driving volume to the pre-selected surgeons and facilities that have a higher quality and better outcomes. And this is basically, basic tenet of leapfrog from very long time ago, that the more you do, then the better you tend to be. That also can result in reduced complications and readmissions, because again, the more you do, you should do a better job, and that should result in lower complications. We talked about the cost variation on the previous page. Most of the time, especially if you're using an outside vendor, they can contract with bundles. Some health plans can do with bundles, or some sort of better pay for performance or fee for service than what you would get normally, so that there would be a lower cost. And if there are bundles, many times we'll also see warranties where the warranty would cover certain types of complications. And also with the bundle, it covers not only the actual procedure, but depending on how it's defined, it can be services pre and post surgery. And then the other part that would be a requirement if you're going to do something like this would be definitely providing member education and support for best outcomes. So as we've looked at this space and definitely looked at the information that we've got, we thought it would be helpful to look at the characteristics of best-in-class features, both from an OEB and PEB perspective, and also to the member. And this would be irrespective of how you set up the Center of Excellence, whether you choose to go through the health plan or whether you choose to go potentially with a third-party vendor. So when you look at the value to OEB and PEB, you are identifying select high-performing surgeons' facilities based on a broad data set, multiple quality sources, and benchmarks. We talked about negotiating favorable reimbursement, bundles with warranties that are lower than traditional reimbursement. Typically, when they look at developing the bundles, they can take different approaches. Sometimes it may be looking at the median price and then selecting some price point that's near that or slightly above or slightly below. Sometimes it can look at that and make an assumption that if there's a certain amount of complications, then you might bump it up a little bit, but it would still be less than what the cost would be in the absence of the bundle. The other is that there would be decision support and early engagement with the members so that you can drive them to the conservative therapy and not get them prematurely imaged by a CT scan or an MRI. From the member's perspective, it does ensure quality of care, which can give them a better experience, quicker recovery, less lost time from work, better quality of life, fewer readmissions. These programs typically do have concierge services where there would be an individual that helps the member navigate the process, especially if there's going to be any type of travel or follow-up care. There can definitely be reduced cost sharing, again, with bundles or with a reduced fee for service. And then some of these also come with a value benefit, such as a travel benefit, fewer doctor visits, integration with primary care physicians. And the travel benefit would certainly be contingent on how you set the centers of excellence up. If you take an east and west approach, then that might mean travel for folks. If there are facilities that meet the quality standard and you have more there, then there could be a less of a need for a travel benefit. Next slide. So we thought it would be helpful to talk a little bit about bundled payments and some of the pros and the cons. And when we talk to the various vendors, it is generally the preferred method that they use for an episode of care. And again, as we talk about a bundle, it's the episode. So it's not just the procedure, but it has a starting point pre-surgery and has a stopping point post-surgery, which could be 30 days. What we did see, and again, when we presented the data to you previously, there is a pretty significant cost variation. For example, spine fusions could be anywhere from about $70,000 to about $160,000, and the same thing on knee replacements. Again, this could be around $30,000 to almost $80,000, and these would be members that would be risk adjusted. So this cost difference doesn't reflect that they're more complicated. It just reflects that some providers charge more than others without any difference in terms of risk or outcomes.
Louis?
Yeah.
This is Tom. I just wanted to make sure about what you just said, because one of the major drivers in cost variation for these procedures is, on the low end, the person who slides through without any trouble versus the person who goes on and develops complications and changes their DRG and all that other stuff, and that obviously costs more. So this is what you're talking about here is the person who's having the same surgery, not with complications, and there still is this huge differentiation.
Yes. Sorry, I'm the
that is yes.
Yeah.
Yeah.
Yes.
Okay. Well, that's
what when I talked about them being risk adjusted, we're looking at apples to apples.
Great. Thank you.
These episodes.
Yeah, that's very important to know. Because that's the two different ways that there's variation is one, just the fundamental cost of the services, and the other one is someone who doesn't have complications and because of that doesn't need extra medical services.
Absolutely, and I totally agree with that, and that's why when we did the analysis, we controlled for that.
Yeah, and we'll need to, and centers of excellence should be addressing both issues: the issue of cost per average case, and then complications and how that drives costs.
Yes, I mean, there's unfortunately, regardless of who does it, there will be some complications. They just can happen, but there is a significantly reduced rate of complications when you're going to a center of excellence or a high-performing surgeon, just because they do more and they don't have as many issues, and that is one of the advantages.
Yeah, and I'm familiar with that. Great, thank you so much. Sorry for the interruption, but I just wanted to make sure I understood the data.
Oh no, that's why we're here, to make sure we cover it so that answer the questions. I know part of the discussion along the way has been, how does this fit into the hospital reimbursement Medicare cap? And although this would reduce some or much of the variation, it's not going to reduce all of it, because not all of the facilities are subject to the cap. There is variation in Medicare rates by facilities, and not all of these procedures are performed as an inpatient. In fact, many more of them are being performed in an ambulatory setting where it may or may not be applicable to the cap. Certainly at this point wouldn't be. So going through some of the pros and cons, pros, definitely you've got a consistent price. If you're going to get a knee replacement, you don't have the tremendous variation that we saw above. The bundle does include a suite of services associated with the procedure. Typically, we do see a warranty for some types of adverse outcomes or complications. It does remove one of the incentives for a provider to perform more care than necessary. it requires the provider and the facilities to coordinate care for optimal outcomes and efficiency, which would include not only the surgeon and the facility, but also the anesthesiologist or any other peripheral services, potentially physical therapy. And it does fit into being a value-based payment model where you're paying based on quality versus just volume. On the flip side, when we look at some of the potential cons, because recognizing that there is definitely an effort around shared savings and pay-for-performance initiatives in Oregon, there can potentially be a downside risk for the provider if they don't set the price correctly, or if in fact they don't organize or coordinate the care optimally and reduce the complications or keep the complications under control. It's also not an approach that manages the total cost of care, but focuses on the cost of care for selected procedures. If you do have a full downside and upside risk shared savings model, it can potentially divert focus of the providers from other opportunities that could yield better savings. We find that not all the health plan claim systems can easily accommodate bundled payment methodology and prevent potential duplicate payments for services that are covered under the bundle. And Jenny, I think that's all for this. I know we've covered quite a bit. You know, Tom, I don't know if you have any other questions or anybody else on the IWG. I know we've had numerous discussions on this over the last about a year and a half or so, but definitely open for questions.
My only additional comments are going to be when we kind of look at vendor versus current health plans. It is in the interests of health plans to have to be able to control the cost per unit and to be able to decrease complications, because what it does is increase costs. So, and health plans want to fundamentally control costs. The reason why it is what it is because we value to a greater degree choice, allowing people to seek care, you know, wherever services are provided, and not guaranteeing or gating this where those services are. So the part of the conversation I think we'll get to is why the health plans haven't done more of this already, and because of that, then having to think about, do you then go with a vendor that does something that it would seem that health plans automatically would be interested in doing?
Yeah, I totally agree. And I, prior to my work at Willis Towers Watson, I spent quite a bit of time on the health plan side and have that perspective as we look at these issues. And in an ideal world, the health plan would be able to do all of this. Unfortunately, we see that they don't always do that or able to do it, but that is why when, you know, we don't necessarily need to flip back to slide 8, but rather than looking at pros and cons of carve in or carve out, we thought it was better to really focus on what would be the characteristics of what you would want, and then can figure out how you want to deliver that, whether it's a carve in or carve out. So, you know, keeping it agnostic at this point of the discussion.
Yeah. This, Jeff, I appreciate that. One question I have is, are we able to determine what our complication rates are through Watson? Or are we reliant on our carrier reporting?
Yeah, so Jeff, this is Jenny. I'll hop in. And you had asked that, I think, on maybe one of our last calls. And so we did start taking a look at complication and readmission rates. And so there is a way to pull some of that data from the data warehouse. And we pulled some high level data and saw some interesting things, but didn't have a lot of time to go in and truly make sure that we were controlling for the right things or taking a look at the right things. But I think that's an excellent next step. So and then of course we do want to reiterate that one of the key things is reducing the complications and readmission rates. The second piece of that, which is arguably more important, is how do we ensure that, you know, the folks who get surgery are the ones who truly need the surgery, and that we haven't done everything we can to steer them to the more conservative therapies first. There's a lot of science behind doing that. And we'll talk a little bit about this as we go through the responses. I'm not sure that any of the vendors that we looked at are doing anything super exciting or terribly groundbreaking in that area of steering people to conservative therapies first. So that's, certainly something else that the group can take a look at focusing on.
Well, I think that would be great. Are you able to put that together for the next meeting?
Yeah. Mm-hmm.
Excellent.
Okay, so let's go. Should we go ahead and move on?
Please.
Okay. So, Rose, we're on slide 11. So this is just a quick review of the request for information process. So just to reiterate, this was not a request for a formal proposal. Literally, we asked everybody to respond to a variety of questions, and what we're doing here is summarizing those responses, and thoughtfully didn't attribute responses to specific COE vendors. We did kind of mention some of the things that MODA and Providence or Kaiser are doing, just because they're already your partners, and so these are things that are already known. But anyway, again, this was more of a request for information just to summarize what everybody's doing, and the goal of it is to use the information to decide what to do next in this process. So let's go ahead and move forward. So who did we send this RFI to? And again, as Margaret mentioned, we did this in December. So I do, if whoever is on the line who might be listening, thank you very much, all of you, for your quick response, because it was, in the pandemic, at the end of the plan year, at the holiday. And so everyone just did a really nice job of pulling together and responding. But we sent the RFI to 5 different vendors that we know specialize in this area: Bridge Health, Durham Health, Cedar Gate, Signify Health, and Surgery Plus. All of them have a little bit of a different value prop that they like to talk about. And then we did hear from the carriers that they also wanted to participate in this process. So we did go ahead and send the RFI as well to Kaiser, MODA, and Providence, and that was really helpful too. So let's move to the next slide. So the sections of the questions that we asked were in the area of, just general experience. What kind of size of clients do they have? Where are they? What's their experience? We asked a number of questions about their network strategy. Do they work with facilities or providers in Oregon, or is it mostly outside of Oregon? How do they select the providers or the facilities to participate in the Center of Excellence? What's the criteria, data that they're using, and what's their contracting approach? Then we asked a number of questions about things like, how do they integrate with the medical carrier? How do they interact with members? We did ask some questions around health equity, and then reporting. And then at the end, we talked about, what are their fees for providing this service? Or maybe I should say, what is their fee structure? And then what, a little bit about the bundled approach, the bundles and warranties. Okay, you want to move to the next slide? Yeah. Okay, so general questions. As I mentioned before, OEB and PEB carriers had, a lot of experience talking about how they've partnered with OEB and PEB to do some, advanced initiatives and unusual contracting relationships. The COE vendors obviously didn't have that experience, but they talked mostly about their experience with large employers using broad data sets in cost and quality to use as the basis for selecting which providers to work with. There were some COE vendors that responded that did have some experience working with either public entity employers or in some cases setting criteria for Medicaid programs in this particular area. All of them mentioned that they had experience with self-funded arrangements, but not all of them had experience in insured arrangements. So definitely something of to be aware of on the OEB side. And then again, they all had different levels of experience working with very large, complex employers like OEB and PEB. Some of them are a little bit more in the mid-size employer group, and then others did have a number of really large employers.
I'm curious, excuse me, Jenny, Jeff, I'm curious, did any of them state that they have experience working with Kaiser?
Now you're asking me to try to remember all. I don't think anyone did. If there might have been one that said they sort of worked with Kaiser, but not in a traditional way.
Okay, thanks.
And Jenny, this is Margaret. Just to chime in with another question really quickly, a question that came in over the chat. And Michael Garrett wanted just to verify that the only organizations that actually received the RFI were able to respond. So meaning that only those listed on slide 12 that were sent the RFI were the only ones that were able to respond to this request.
Correct. Yeah.
Thanks.
Mm-hmm. Okay, so let's go ahead and go to the next slide. Network strategy, yeah. Okay, so one of the fundamental questions I think for the innovation work group is, what's the interest in maintaining the care for these services within Oregon versus outside of Oregon? Because most of those who fell on the vendor side, the specialty vendor side, tend to, they already have established centers of excellence outside of Oregon. And the response was, when we asked the question, and I don't know the exact question, but it was something like, would you recommend developing a custom network in Oregon, or would you recommend steering members towards your national network of centers of excellence if you have one? And I'd say most of them said, yeah, they'd be willing to curate a special network, but they would recommend a combination of ones that have already been determined or established and this and some kind of a custom network. And then obviously on the carrier side, their focus, they were all very supportive in wanting to build a center of excellence model for OEB and PEB, but they did focus obviously on their own network. So Kaiser was saying that they, in essence, have already developed that within Kaiser. And then Providence said, yeah, we want to do that, but we would suggest using the Providence networks as the basis. And MODA said pretty much the same thing, that they would be happy to develop it, but they would want to use the MODA already participating preferred network as the basis of that. And I think even MODA even went further to say that they were proposing doing an application process to specific facilities in order to establish that. And I think that's the kind of the key takeaway on this slide. I don't know, Louis, if you have anything else to add.
Can I ask a question? This is Sean.
Oh, absolutely.
This is kind of a technical question, just for my knowledge. Related to the national networks, Are there special? I'm sure that there are, but how big of a deal, I guess, is what I'm really after. Are the contracts or the special contracting necessities around going out of state? You know, like when it comes to mental health, I think you have to have a license for that state in order to be, in order to, provide services to a person from that state. So therefore, you're kind of, unless someone has two licenses in two different states, which is pretty rare, you can't do that. On the medical side, is there anything like that? Like, I mean, if you have a medical degree, you have a medical degree, and it count. You know, it's the same. There's no special rules or anything like that. Can you speak to that a little? Like, is that a big mess, or is it kind of easier than it sounds?
Well,
So, Sean,
go ahead, Louis.
yeah, I think what you're raising is definitely pertinent to the issue of telehealth because you could obviously have a telehealth provider that's sitting in Washington, for example, but they're talking to a member that's sitting in Oregon. And in that scenario, yes, the physician would need to be licensed in the state where the member is receiving care, which is where they're sitting. When you're looking at centers of excellence, if a member travels out of state and has care at that facility, then they're actually getting their care in that state where the center of excellence and providers are licensed, and they do not need to have a license in Oregon where the member lives because the member has traveled and is seeking care at their facility. Does that help?
That helps a lot. And I have one follow-up question. I know this is gonna, I don't want to go too far in this direction, but it is sort of related to what we're up to here, and it's just kind of from my background. Let's say that you travel out of state for a procedure, right? But part of the procedure, and that makes sense what you just described. I'm following you there. But part of the procedure and part of what we're expecting from a center of excellence is the pre and post kind of, talking it over and not just literally their ability to actually do the procedure, but actually the things around it, the recovery and so on. And it seems awfully likely that some of that would be on telemedicine. Like that would be, you don't literally have to fly to Chicago to actually have the conversation with the doctor about but would that get sideways with the rules there then?
Yeah, so, and I thought I saw something pop up on Teams about interstate. I mean, obviously as part of COVID, there were some relaxations relative to treating COVID, but again, I don't know that will persist after COVID, and it's not really what we're talking about here. But in general, these folks that are going to be treated would be seeing a physician in Oregon, a PCP, most likely, maybe an orthopedist, but probably more likely a PCP. And that physician would have typically ordered the conservative therapy, have notes, and he or she, if they're making the referral, would then share that with the facility. They would typically, if they were going to do something virtual, it would probably be with the member sitting in the PCP's office so that there is a Oregon licensed physician present. But most of the care would involve the member actually traveling to that facility, and there would be an assessment. So it's not that they just show up and they go to the OR and get surgery. A part of the COE is it would do their own assessment and evaluation of the member. And what the specialty vendors report, the health plans don't do quite as good a job of reporting, but there are a decent percent of these folks that go to these centers of excellence that the center of excellence deems they're not really appropriate for surgery and they need other therapy or conservative management. So they would go back to their PCP for that therapy.
Sean, this is Jeff. Was your question more oriented towards the referral process to a provider inside the COE? And in other words, for this surgery, we recommend that you go to this facility in another state?
Yeah, I mean, I think that answer kind of covered what I was up to. Like,
Okay.
you know, that there's basically that scenario, right? I mean, there's someone flies. I'm just making this up. If someone flies to wherever it is, Chicago, and they get an evaluation, and they think, oh, I might be going there for whatever, some sort of surgery or procedure, and then they get there and they're actually like, actually, this is not a good idea for you. And they fly home having not done that, as opposed to doing some of that on the phone, that kind of thing. And that kind of answers my question, though. But I'm hearing you that there's also this kind of like local connection that one way or the other is needed anyway. So I think what I was wondering about it, I have a better understanding of it now.
Yeah, and I know in the past we've discussed expert medical opinion where members can get these secondary consults. So part of this upfront piece where the Center of Excellence evaluates the member, to the extent that it's done virtual, it would fall into more of an expert medical opinion type process versus actually treating per se. But you're exactly right. There could very well be a scenario where the member travels to a facility to be evaluated and think that they're going to get spine surgery or knee surgery, and they may not, based on the evaluation of the specialist at the Center of Excellence.
Yeah. Mm-hmm.
Okay, makes sense.
Okay. Well, this is all also closely aligned with the next slide, which is on quality. And one of the key aspects to really understand is, what's the basis that the either vendor or potentially carrier would use to mine data, like the complications or the readmission data or the mortality data, to actually establish who are the top performing surgeons and facilities for these procedures. And so there was a variety of different responses. On the carrier side, they are, obviously using their own book of business claims data set. There were some other responses, such as they would pull info from NCQA or HEDIS or specialty publications. Providence did have a specific pathway developed for tracking member compliance. And then there's the note here about that MODA proposal for doing a more formal vetting through an application process. How the vendors typically approach figuring out how to curate a network is that they tend to use a much broader data set. So they can either use the claims data from the client, if they're a very large client, and they tend to supplement it, not all of them, but I think a majority of them would supplement it from other data and quality sources that they purchase, such as Quantros or finding CMS data or some of these others that you see here on the slide. Some of them will access data from Optum or the Blue Shield network. Again, all in an effort to gather more information about a particular provider's performance. So this is just something that I think the innovation work group, maybe want to take a look at, because, certainly each of the carriers has a relatively limited set of metrics on their own performance, but, it's not going to cover all 4 million residents here that might, they're not all seeing one surgeon, but, to the extent that you can use a larger and wider net to collect this data, that's great. There are some, for example, Quantros does attempt to do that. They use, you know, and employers can purchase that data set as well. So you can find quality metrics at the surgeon level. And I think ProPublica also provides a public database about individual physicians or surgeons' performance in certain things like knee and hip replacements and back and spine procedures and a variety of others. And, you know, there's pros and cons to all the different data sets, but I think that's one that's really different. I think that's anything else, Lewis, that you wanted to add?
No, we're good.
Okay. Okay, so that's quality. We asked on the next slide, we asked a few questions about how do you integrate, or what experience do you have integrating with medical carriers? And there wasn't a lot of experience on the vendor side in working with MODA and Providence. There was one vendor that said they were in development with MODA on something, and I don't know that anyone really did say that they directly work with Kaiser. They might be partnering with Kaiser on some other effort, but in terms of quality, but no formal alliances there right now to speak of. And then, as I mentioned before, you know, a lot of experience working with self-funded employers and not a lot of experience working in more of the insured arrangement. There's comments here about using predictive analytics to identify members for outreach, and the carriers all are doing a fair amount of work in this area already, just in general, maybe not specific to knee and hip replacement, but just sort of general predictive analytics and risk profiling for their members. And the vendors are also doing that, and some vendors were doing a little bit better job than others, but in general, they're all trying to identify early on which patients might be down the road seeking these kinds of services and trying to connect with them ahead of time. Okay, any questions on this piece? Okay, so under member experience. So member experience, and Lewis talked, I think, a little bit about member experience. A COE, formal COE vendor, it typically does spend a lot of time building concierge services or other kinds of assistance services directly with members. And part of the reason is maybe to get back to the comment that, you know, Dr. Siltebeau mentioned early on, which is, hey, part of the deal with this Center of Excellence strategy typically is narrowing your choices. So we're essentially, in some cases, going to be telling members, you know, if you want knee surgery, this is the only place that we cover, or this is the place, if you go to one of these Centers of Excellence, you're going to have the best cost sharing. And so, you know, it's really important to help members understand why that decision is being made and what data went into making it. So there's a lot of resources established on the vendor side for, you know, understanding which members are likely to seek services, and then helping them, you know, navigate the system of setting up the travel arrangements, setting up the pre-operation services that you're going to need, and evaluations that you're going to need, and then giving them a lot of information about why that particular surgeon or facility was selected to participate in the Center of Excellence. So anyway, that's I'd say that's kind of the rundown of member experience. Obviously, the carriers are also investing a lot in member experience, but it tends to be, again, at the sort of organizational broad level. I'm not going to read all of the different bullets because I feel like that's going to take a long time. I think those slides.
This is Tom. I just want to point out the second bullet that you have there, where you say vendors place a high focus on factors of BMI, nicotine use, and comorbidities, particularly diabetes. Those three will drive hugely what happens in terms of outcome. So any process that doesn't include focus on BMI, nicotine use, and diabetes is going to have a poor outcome. So that's just an important thing to keep in our mind. And the fact that vendors are saying that that's important. My guess is that the healthcare providers within the carriers are also, again, the good ones are going to pay attention to it because outcome is hugely driven by it.
Good point. That's a good point.
Just as an example, infection rates for knee surgeries within the Kaiser Permanente system, and this is like 15 years ago, back when I kind of was involved with it, the infection rates were 10 times higher for people with BMIs greater than 40 than those below 40. That's my memory. You know, I might be off by a factor of 2, but still huge impact in terms of outcome.
Yeah. Very good point. I would say just, you know, remembering the responses from, so obviously on the carrier side, they don't always have that information, right? Kaiser does. On the vendor side, they attempt to collect that information through the screening process. But I will say some of the vendors were more advanced in that area than others.
But the carriers, if they're going to go to a point of centers of excellence, they need to do it to insist that their providers capture that information and come up with a treatment plan that relates to those risk factors, and have to be able to be at a point of saying, no, you don't get your surgery until you quit smoking for 6 weeks, or, you know, get your BMI below 40 and other, you know, get your diabetes under control. Those are the, and when you talk about member experience, from the member experience of the member wanting the surgery because they're having a problem, that's one thing. The other part of it is that they're going to have a surgery that, whether or not they have complications, you know, or you know, a disaster or a success. So, you know, both elements need to be looked at, and that's all.
Yeah, and I think that's a really good thing to point out. I kind of maybe breezed over that in a prior slide, in that, you know, right now the carriers, right, a lot of the predetermination work in terms of, you know, who's going to get surgery is primarily through that prior authorization processes, in addition to some, you know, care management programs. But, you know, the prior authorization process is going to basically say just those who really need surgery, or, you know, those who qualify for surgery are going to get surgery. It doesn't necessarily say, gosh, this person really would benefit from a lot more, you know, physical therapy first, or, you know, they'll take into account some of the BMI and some of those other things, but it's not quite as intense, right, as some of the specialty vendors, not all of them. So it's certainly something to keep in mind. But again, going back to that first comment that you made, it's because health plans have to take that fine balance, right, of trying to be agreeable to all members and give them a lot of choices and coverage, right, versus narrowing their choices, which doesn't end up making, sometimes members can be unhappy about that, right? You have a really strict criteria. So it's not, I wouldn't say that's necessarily a fault, but it's something to look at, intensifying. if you stay on the carriers.
Well, and Jenny, I would add that, and I can't speak to the contracting in Oregon, I can speak to it here in Texas, but there are some facilities that contract with their health plan on the stipulation that they can't be eliminated from a narrow type network. So not necessarily COE, but from a narrow network. So that is a restriction that can sometimes happen on the carrier side and not necessarily on the vendor side.
Okay. Well, we may want to kind of come back to that topic as well, but let's just go ahead and move. I'm going to go a little bit quicker through these. On the next slide, we did ask the vendors to talk a little bit about their efforts in terms of health equity. And there's a lot of information here. I would say, you know, again, the carriers are doing more on an organizational level, and then the vendors, because just of the nature of their business, are focus their answers on how they would help members seeking these particular kinds of services and what they would do to provide them some assistance as needed. But I think there's certainly more that everyone can be doing, but everyone responded that this is an important area of focus for them to continue evolving. So let's go to the next slide. Reporting, and again, I'll just be pretty brief about this piece because, you know, so on the carrier side, more than willing to develop the right reports to go along with the Center of Excellence strategy that is developed. And on the vendor side, they already have, many of them already have some reports specific to how to track quality providers or the complication rates or the savings. And it all tends to be based on what kind of guarantees are in place with the employer, then they center the reporting around what those guarantees are typically. So let's talk a little bit on the next couple of slides about, you know, what's the pricing structure, how do these vendors, specialty vendors, get paid for setting up centers of excellence. And so, you know, just as a basis of the actual provider reimbursement for the surgery, those are always done on a bundled payment arrangement, at least according to the vendors that we talked with. And so the COE vendors will either take a percentage of the bundled payment or charge a flat per employee per month fee to the purchaser, or there's a mixture of the two approaches. We asked about whether they tend to offer performance guarantees with fees at risk, and majority of them said yes, they do. And they, I mean, this is a pretty typical response, and it's very common for these vendors to say, yes, we're going to guarantee a certain level of return on investment or positive outcomes or member engagement targets. Just on these, it's great to say that you'll do it. I guess the devil is always in the actual calculation method for how they get done. So that's something to pay attention to if, you know, if we want to go down that route. Okay,
Can you give a ballpark though? Is it 1% of total cost in the area? Is it 5%? Is it 10%? What type of cost are we looking at adding by this administrative structure?
I mean, it's all going to depend on whether, you know, this is both OEB and PEB, or how it's, and whether you want them to develop a custom network or not. But I would say if you're going to do a PEPM fee structure, it's going to typically be less than $5 PEPM. Then it helps. And it's on the whole membership, not just the participants.
Yeah, I don't know. I don't know what I'd be able to figure it out if I knew what the cost for orthopedics was, PEPM, but I don't. So we'll talk about that later. I don't want to slow you down.
Okay. All right, we'll come back to that one. So then let's talk a little bit about the bundled payments. Now, so Lewis talked talked quite a bit about bundled payments and warranties. When we asked the question of, how they structure this, all 5 of the specialty vendors did say that they focus on using bundled payments and warranties. They typically talked about a 30-day warranty, although, it's certainly appropriate to consider a longer period of time for the warranty. Most of them did say that the bundled case rate would range between 100 and 150% of Medicare, but they definitely said it would be, especially if you're going to develop something custom in Oregon, they would take a look at the claims that have been paid to those facilities for those episodes and negotiate that down. So the whole idea is to drive volume to those particular providers and set a really aggressive payment bundle. And that should be more favorable than what you pay today, obviously. Any questions about that? Okay. Okay, so really now we're at the point of talking about, well, what do we do with all of this information? Oh, we got one slide here just about implementation timeline. And so, this is a question where sometimes people get really aggressive and optimistic, but so some of the vendors did talk about being able to set up a custom regional network within 6 to 12 months. And that's fine. What happens in the responses that we got is that several times the concept of the provider being willing to take the bundled payment was a kind of a critical factor in the criteria about whether they were considered for the network. So obviously there's a lot of detail to be understood about what's in the bundle, how is it, what's in the warranty, and how is that structured, and so if they're going to do that here in Oregon, I guess I would say there's a lot of very unique payment arrangements already happening with OIV and PEBS carriers, and that would add a little bit of complexity. So it could take longer than 6 to 12 months, is I guess what I would say. But there are, if OIV and PEB decided this COE idea sounds really good, and we'll talk about this on the next slide. If we want to move forward with a more formal RFP and understand which facilities we want to send people to that are already set up, and maybe it's in a different state, that certainly would be a lot quicker to implement. Okay. So it looks like we're moving to the next slide, which is our discussion slide on what do we do with this information. And so I think at this point, it's good to check in with you all. If there's a compelling case to move forward with a formal procurement, we can talk about what that might entail. I've got a call out here that I need to be aware that we have one program that's insured versus a different program that's self-funded. So that's one path to consider. A different path that the innovation work group could consider, not sure if it would be longer or not than a public procurement, but it's certainly possible to establish some of the better features of the vendors that operate in this space into what the carriers are doing. So, if Providence, for instance, said, hey, we can select, 2 facilities based on what we're seeing that would qualify as a center of excellence, and they meet all the criteria that one of your vendors would do, doesn't it make sense to use the infrastructure that we have? And that's certainly something that the innovation work group can do. I think the interesting thing is, what quality criteria do you use, and is everybody using the same criteria? And then kind of who's the monitor of that criteria? there's a few, I've got a call out here to the BRE Collaborative. I don't know if the group has read some of what they have put out, but they've done some extensive research. This is a group in Washington that has, it's kind of like the healthcare, with that. Anyways, there's a similar group in Oregon that kind of puts together a quality framework for various types of healthcare procedures and episodes. So anyway, the BRE Collaborative has spent a fair amount of time saying, hey, here's the best practice for how you set up a center of excellence, and here's the criteria that you should use. So certainly that can be leveraged. Probably need to be updated.
I'm definitely in favor of pressing forward on a program, but I really would like to quantify the problem first. And that is, are we having it? How much of an issue, if any, are we having with the facilities in Oregon?
Okay.
So I think you've already agreed to give us some data on that at the next meeting.
Yes, absolutely.
Okay. Other members, what would you like to see as next step?
Looks like JJ has his hand up.
Yeah, but he's on mute.
Oh.
Come on. There we go. Sorry, I was being patient and my computer was not being nice. The question I would have would kind of be answered through the RP process, but we have a fairly large group, 300,000 people between OEP and PEB, and I would have questions / concerns about the ability to facilitate this function. So in the RFP process, we need to ask some specific questions about, what is your ability to suddenly handle this large influx into your business?
Yeah, and
Overall,
unfortunately, go ahead, JJ.
I said, I think it's, we did a lot of work on, there's a lot of potential cost savings in this avenue. Center of Excellence is a tool potentially to facilitate that. So I'm in favor of progressing and seeing what we can get out of it.
There's definitely some legally required RFPs that are priority right now. We're just, as everybody knows, we have a really limited staff
Sure.
in our contracts area.
This is Tom. We were able to do centers of excellence for bariatric surgery, and with OEB. I don't know if PEB did this, followed the same route for that, but we could use that as an example, and kind of blend that with reference pricing. That would. I think that would be the model that we could be looking at that could be relatively quick. I'm not sure. I don't know enough about what the vendors offer, so I'll need to do some of my own work to look at the 5 that responded and see where they are and what type of things that they do, to be able to comment on that element. My only additional issue is whenever you bring in a new program of outside people, what you've done is that you've increased the cost structure. Your hope is that what they're offering will lower the overall cost so that you're able to swallow the additional administrative costs. But if you're able to do it without that additional administrative load, that's better.
Mm-hmm. Okay.
Yeah, so this this is Sean. Kind of following on what Tom was saying. So we just got out of the PEB board meeting this morning, and we're going over the the dollars and cents, and talking about our administrative costs in general are higher than, kind of national benchmarks. And there's various reasons for that, some of which has to do with these kinds of things where we've added programs to save money in the long run. And so it's kind of, thinking about this discussion that we've had today, this would, to what degree, does this include higher administrative costs? Obviously, if we're going with the vendor, there's administrative costs added. If there's something where we can kind of change expectations with current carriers where it doesn't, perhaps the administrative costs are not quite so pronounced, because you're changing something rather than adding something. That's a different, something to think about, but definitely worth talking about. We're presuming there's a cost benefit, that in the end we come out ahead, right? Because we made this investment. It's like an investment, and you have lower costs somewhere else. But if that doesn't materialize, we've kind of like added on, So there's that, and I don't know how we tease that apart where we're actually looking at numbers. I understand that that's difficult. It's like predicting the future, but how we can get close to fully understanding the dollars and cents of that. The other thing, and I think that relates to what Tom was saying and also what Jeff was saying, I think we actually need to look at some numbers, like what does this look like? That all being said, I kind of have a question for Ali that not necessarily that he needs to answer right this minute, but our other project is in the future is like this large RFP kind of Lodestar, overhaul, and like what's the time frame? Are we thinking the time horizon on that? So it's kind of like if this takes 3 years, and the other thing, but it delays the Lodestar thing by another year, like if they both come to fruition in about 3 years, should we have focused on kind of the big overhaul instead, or can we do both things? That's kind of a capacity question, I guess, timing and capacity. So those are just a couple things. Couple questions for us to consider as a group.
Yeah, so the PED board has already talked about a medical RFP in the coming couple of years, and this is obviously something you could do as part of a greater, incorporating wellness and all kinds of different things into a major medical RFP. With that said, we have a consultant RFP that we really have to get through by law, and so that'll be over the next few months, and hopefully that'll all be determined by the end of this year, and then we can talk about next RFPs, next steps. So
this is Jeff. Ali, if HB 2810 were to pass, how would we address that?
Yeah, that's one of the questions we actually have in the analysis, whether that would require an RFP. We'd have to look more closely at, and so yeah, that's a good question.
So that's really leading us to offer CCOs, right?
That's what the bill's purpose is, yeah.
And wouldn't that kind of take away the authority for us to mandate for that provider, a center of influence program?
It's a good question. I'm not sure
Potentially,
exactly
I
how
guess.
this, yeah. I would assume so, but
Okay. So it's sounding like the public procurement or formal RFP process may be, it may put this on the back burner. And so then the question is, okay, is this still an idea that OEB and PEB want to pursue? The next best idea is to pursue that with the carriers. Is there, and so maybe it is that next meeting we'll come back with some more information on things like the complication rates, the morbidity rates. We may be able to pull some re-pull some of the quality scores from different facilities or providers. I'll have to think about doing that.
Jenny, I'd be interested. Oh, sorry. I would just say I'd be interested in any member disruption kinds of, even from the previous implementation of the OEB bariatric surgery, COE, and if just getting reimbursed or having a lower cost share is enough, to really make somebody travel back and then potentially travel a couple more times.
Sure.
And this is Tom. So the data that we, to be able to compare maybe facilities, I don't know if it means comparing surgery groups, but it would be looking at both the variation in cost for, in a way, the uncomplicated procedure, and then where do you have the complications? And you could look at complications by things like readmissions and surgical infections or hospital associated infections and ICU admissions, things like that. So you really need to get to that level to be able to understand, to be able to, as we tell our health plans, to develop these things around which criteria we want them to develop them in. And as Ali just talked about, the issue of the member disruption part of the distance. I know that we had some of those conversations with the bariatric surgery. The reality, though, is that just the numbers of bariatric surgeries were so much less than what we're talking about with knee, hips, and spines.
Yeah, and it was a double thing where it was, yes, there was a center of excellence component attached to it, but there was also a reference price component attached to it, which is, I don't know, two sides of a coin, maybe. I'm not sure, but
well, I think the reference price is essentially what it's approaching what that bundle is.
Yeah.
But the idea is that we, for bariatric surgery, for sure, it was, do you do enough cases? Are you reporting your data to the National Bariatric Surgery Registry? I think there was something of that long enough ago that I don't remember all the details, but.
Yeah. Okay, so it sounds like continue the discussion, provide a little more data to help frame the issue that we're trying to solve.
Yeah, I mean, especially given the disruption and the spacing of where our employees are geographically and all that, let's keep moving towards this goal, but just make sure the steps are deliberate and thorough.
That sounds good.
Great, thank you. Any last thoughts before we break for 10 minutes? And Margaret, you've got Sarah in the queue coming up here.
Yeah, Sarah Bartleman will be here next with an update from the Sustainable Cost Growth Target Committee recommendations.
Okay, let's reconvene at 3:15.
Great.
Thank you.
Thank you. Sarah, are you on the line yet?
I am here. Hello.
Hey there. How are you?
Good. How's it going?
Good, thanks. Are you able to see my screen? I should be sharing your slides, I hope.
I am seeing them.
Okay, great. I will toggle through them for you. So just let me know if you want me to slow down or go faster or whatever.
Okay. I only have a couple, so.
Yeah. Okay. Sounds good.
Well, let's go ahead and reconvene. Hard to tell without a lot of pictures who's in front of us at the moment. But I'll say welcome back, Sarah Bartleman. Glad to have you here. And you have an update for us.
I do. Thanks for inviting me back. I think the last time we talked about the Healthcare Cost Growth Target Program was back in September. And we provided an update, a lot of the background on the intent of the program and the implementation committee and some of the decisions that had been made through September. So today I thought I would give you an update on the remaining decisions that the committee has made at a high level, talk a little bit about where the final recommendations have landed, and what's coming up next for us in 2021. So I don't have many slides, but I'm happy to jump around and answer questions after I give this high-level update. So next, please, Margaret. And one more. So the implementation committee finalized their recommendations this month. They voted to approve them on the 12th. So we are considering them sort of final, and they'll be submitted to the legislature either this week or next. So coming up real soon. But the last couple of details that the implementation committee addressed between November and January were accountability and governance. So accountability was sort of the biggest conversation the committee had. We really left it till the end, had some very good discussion about what accountability means. And when we're talking about accountability in the context of the Cost Growth Target Program, we're talking about what happens if a payer or a provider organization does not meet the cost growth target in a given year. So we proposed, and the committee agreed on this tiered approach that I'm going to talk through. So a couple of things, foundational pieces before that, the committee was very on board and strongly agreed that all of this is based in a foundation of transparency and collaboration. That is certainly the agency intent. The committee agreed. We want this program to be as much about that transparency and collaboration, whether that's public reporting and various efforts to address cost containment. Some of that might be advancing towards value-based payment targets and other initiatives, low-value care. There are a lot of different ways that we can all be working together to meet the cost growth target. So all of that is sort of background foundational work for this. When we get to actually determining who is accountable or who should be held accountable, we have these 3 steps. So the first thing we want to do is ensure statistical confidence. So this is something that's specific to Oregon. The other states with cost growth target programs are not doing this. We're taking a little bit more of a robust approach here to make sure that only payers and provider organizations that exceed the cost growth target with statistical certainty would be held accountable. So essentially the way the process will work, we will collect data from all of the payers. We will calculate cost growth target performance for payers, providers, at the state level, at the market level. We will then look to see what that looks like in sort of absolute numbers, and then we'll conduct some variations on t-tests. I don't want to talk too much about the statistical methodology. It's all written up if anyone's curious, but we will look for essentially non-overlapping confidence intervals to make sure that if it looks like an organization has exceeded the cost growth target, they really have, and it's not due, we're not seeing that because of small numbers, we're not seeing that just because of noise or random variation year over year. We can be confident that it was truly above the target. So if an organization, a payer or provider, is in that situation where, one, they were large enough to be part of the reporting program in the first place, they exceeded the target, and statistical testing bore that out, the first accountability mechanism that would be triggered would be performance improvement plans. But before we get to performance improvement plans, there is also a determination of reasonableness. So Senate Bill 889 from 2019 used justified and unjustified language. The implementation committee didn't think that was the most appropriate framing, so we're talking about reasonableness. And so in any given year, there are reasons why cost growth might be above the target. In 2020, there was COVID-19, and we don't know yet what that's going to do to healthcare cost growth in the big picture. But that's certainly a good reason for exceeding the cost growth target, or sort of an unforeseen reason. So the committee spent a lot of time talking about what some of those considerations might be, and what that collaborative process would be between the state and the payer or the provider organization to understand why the target was exceeded. So only after someone exceeds the target with statistical certainty and they don't have a good reason for exceeding the target after those conversations would they then be put on a performance improvement plan. And those performance improvement plans, probably similar to what most healthcare organizations are familiar with. Certainly we have some good models for that over in the CCO world. They would be multi-year plans, something that would be developed collaboratively between the entity and the state, probably OHA, but in some cases OHA and DCBS, particularly for the commercial market, to say these are the reasons that this entity exceeded the target. These are the things that we're going to do to work to bring us back down and meet the target in subsequent years, with the understanding that there's multiple years to implement those changes and demonstrate improvement. So that's the annual cycle of collecting the data, confidence, understanding reasons, and determining whether or not PIPs happen. Then the committee talked about, well, what if PIPs aren't enough? What is the escalating accountability mechanism? And that's some other language from the original statute. And the implementation committee considered a lot of different options, price caps, rate review, a bunch of other things, contract review, and where they ultimately landed was on a variable, meaningful financial penalty. So this would be triggered for payers and provider organizations who exceeded the cost growth target with all of those other conditions that I already described in any 3 out of 5 years. So on a rolling basis, an organization who was really failing to make meaningful progress, really failing to demonstrate that cost growth was being contained, really failing to implement the PIPs or make progress on the PIPs, all might lead to triggering that financial penalty. The implementation committee did not agree how large that penalty should be. There's still some discussion that we need to have in 2021. So it's not a flat rate because the committee wanted to make sure that it wouldn't be something that large organizations could easily, I'm going to say write off, but essentially incorporate into the cost of doing business. So it would likely be tied to the amount that that organization has exceeded the target. So an organization that has exceeded the cost growth target by a lot would have a larger penalty. A larger organization would have a larger penalty, and a number of other factors that OHA and DCBS might take into consideration in setting that. So obviously there's some level of subjectivity here. The committee is okay with some of those parameters, but definitely flagged a number of things that need more discussion coming up this year to help finalize all of this approach. Let's stop there for a second. Any questions about this?
Yeah, this is Tom. I had two questions. The first one was, do you know what percentage of Oregon's delivery system is too small so that they won't be included in that statistically confident level?
Yeah, good question. So the short answer is I don't know exactly. The slightly longer answer is we spent a lot of time trying to figure this out, and we have a couple of different thresholds. So the first threshold is how big do you have to be to report data? And there's a threshold for number of lives, number of members, and number of unique patient lives that you have to be even submitting data to this program. And I can send some follow-up data around that show what the cut point is. So there are about 100, there are about 100 some payers that meet that threshold for number of covered lives in terms of needing to report data to the program. Then we have a slightly larger, slightly higher threshold of large enough for public reporting. So that would be 10,000 lives or 10,000 lives in total or 5,000 lives in a specific line of business, Medicare, Medicaid, or commercial. So if someone is large enough, whether that's a payer or provider organization, is large enough to meet that threshold, then their performance would be calculated compared to the cost growth target and then tested for statistical confidence and all the other steps. Obviously, the smaller organizations that are closer to that size threshold for public reporting are probably less likely to demonstrate statistical confidence. I mean, depending on what exceeding the target looks like. But if we're talking about a small amount of money in a per capita amount, or if we're talking about a very small percentage, 0.1% over the cost growth target, it's likely that will wash out in small numbers.
Yeah.
We're doing a little bit of testing to figure that out, but we don't have a concrete list of definitively in or out yet.
Yeah, the only reason I add is that I say this is that if it's 5% of the delivery system in Oregon, it's no big deal. If it's 50% that are not included in it, then it's a big deal. So that's just one that needed to be answered.
Yeah, it's most of the delivery system that will be included, or it's most of the payers that will be included. And then when we talk about providers, there are a number of ways to slice this because we are focusing on larger provider organizations,
Yep.
so health systems and hospitals, larger medical groups, but not the independent small doc shops or specialists. So depending on how you want to list that, I don't know if that comes out to closer to like 50% of all doctors, probably not the case, but certainly the majority of lives and dollars.
Yeah. So I don't care so much about the payers. I'm concerned about the providers because that's where cost is generated in general.
So we're working on a preliminary list this month of using some of our all-payer claims data, which providers appear to meet that threshold. So this obviously won't be the final list because it's not the official data source, but it should be a reasonable heads up of who might be included. I
have one more question, and again, I'm a newbie on the group. The what happens when a provider or a payer, for that matter, has a really good year? So you have a 3.4 and it goes then to 3% per year. But let's say 1 year you're at 1%. Do you get to bank that additional 2 to 2.4% to be able to
No.
use for the next year?
No, it is a year-over-year comparison.
Yeah.
So it's percent change in per capita growth, or not. It's percent change in total medical expenditures year over year. So no, you don't get to bank, but you would essentially be starting. Did you grow from that lower baseline versus the higher baseline?
So what you've done is you've created an incentive for there to be at least a 3% or a 3.4% every year.
Yes, that is one way to put it.
Well, I mean, it is. I mean, if you can't bank it, I mean, we've dealt with this on the OEB board of, looking at trying to figure out what the rules that the 3.4 growth target has been. And it's not logical that you can't, but I understand how decisions are made. That's all.
Thanks, Tom.
Yeah, the PEB board this morning, I was looking at -6 to 7%, and that was only partially through the year. It's going to be even greater than that. So it's a resetting of the baseline there.
Well, and it's because of COVID. So,
totally.
I'll start figuring out ways to spend money, Ali. Have board retreats in, I was going to say Hawaii, but I think you now need to go to Bali or something.
It's too late. The plan year ended.
Okay. You're really in trouble.
Are there any other questions about accountability before I move to the next update?
My only other comment when I read the report is that just as Ali just talked about, 6% down because of COVID, if that resets it at 6% lower than what it was, there's no way that the PEB board is going to be able to reach that for next year. It's just going to be impossible.
And obviously I can't, I'm not the deciding voice that will make these decisions on,
I get it.
Reasonableness, but I would say that a rebound in utilization and cost post-COVID is certainly a good reason.
Yeah. Okay. Thank you.
Okay, let's go to the next slide. So briefly, the committee was also charged with thinking about governance for the program. We realized that we had overlooked something in translation between the original statute and the charter that we drafted, and the implementation committee did not actually sunset this month. They have a whole nother year. So we asked them if they would be willing to stick around and help us continue to think through some of these operational decisions, and they have agreed to. So we are going to continue the implementation committee through 2021. They might meet a little bit less frequently, and we do have some membership changes that will be happening, but we will be continuing. We're also standing up a technical group. I was hoping that would happen in January, probably not till February at this point. And that group will be open to all payers that will be asked to submit data, as well as any provider organizations and other interested parties. And that group will function similar to the all payer claims database tag, and will be focused on the data submission and validation process. That's not a decision-making group. That's more of a working group on the technical side. Then later this year, we will work on a charter and proposed membership for a future committee for 2022 and beyond. So there will be a committee that provides some oversight and some direction, and they have some specific things to do, like resetting the cost growth target in many years down the road. Also things like monitoring what's happening with cost, price versus utilization, looking at key cost drivers. But there's an ongoing conversation about what the role of the new committee should be versus the role of the policy board versus some of our other committees. And so that future governance is still in flux. We know we want this to be a committee of the policy board because that's where this lives. But in terms of who does what and who convenes the public hearings and what oversight actually means, there are still some conversations to figure out for that future state of governance. Next. And then just a note on the final recommendations. So we provided a draft report to the committee for review in late December. That report and the summary of the recommendations were approved by the policy board on January 5th and by the implementation committee on January 12th. We are making a number of small changes to the report based on committee feedback. None of them are really substantive, I would say, mostly clarification of things, adding a few more appendices, and then the final report will be submitted to the legislature soon. So the full report is, the full draft report is currently on our webpage if anyone who hasn't seen that would like to see it. And we'll have the full final report out hopefully by next week. There are also some supplemental documents that are in the December committee meeting packet that might be of interest if anyone's looking to dig a little deeper into some of the accountability and operational pieces. We really had to start thinking about operationalizing this in terms of how the process would play out and what the timeline actually looked like. So there's a lot more detail about the steps and who does what, like what's OHA's role, what's the payer's role, what's the provider's role in this annual process document that we have. So if anyone's curious, that's another good resource. And last slide, just a couple things that are upcoming. Final report to the legislature going in this month, like I said. There is an accountability bill for the 2021 session. It is House Bill 2081. If you remember back to Senate Bill 889 in 2019, we were authorized to stand up the committee, to launch the program, to collect the data, to begin public reporting, to do everything except actually turn on that accountability mechanism. So we had a placeholder for the session, just waiting to drop in the final recommendations from the committee. So House Bill 2081 is it. The original draft of 2081 does not have the final committee recommendations, but there is an amendment circulating, so it'll probably be the first amendment that shows the PIPs and the financial penalties that I described earlier. The value-based payment compact and implementation work group, that work is all moving forward. Jeremy is checking in with folks, both some of the payers and provider organizations that are on the implementation committee and some of the other stakeholders that we've talked to check in to see where we are on compact signing. And then we're looking to convene the group to do the signing and then launch the work group to implement the compact, hopefully early this year. I don't have exact details on timing. I think this group knows that both the PEB and the OEB boards were asked to endorse the compact and agreed to do that over the last month. And then finally, we are going to be starting data submission for baseline. So our first measurement year to actually compare to the cost growth target is calendar year 2021. We won't collect that data till 2022. Official accountability won't start till even later than that, but the committee did agree and we will start collecting baseline data now. And I'm saying baseline data not in that we're basing cost growth on this and looking at percent change from these years because it's a year over year comparison, but rather we want to understand what the trends in Oregon were looking like leading up to and during COVID. So we will be using this to hammer out the details of our data submission process and also get a lot of hopefully really interesting and valuable information to better understand the system. And we have two reports in development that I'm hoping will come out this quarter. One is a cost growth trends report. We have been using the all payer claims data to model an analysis that the Healthcare Cost Institute produced. So we know that cost growth is happening, and we can look at that by market, but we want to unpack that a little bit and see what's actually driving those cost growth trends. Is it price or is it utilization and where? So we have one report that digs into that. And then we have a second report that looks at hospital prices, comparing Medicare, Medicaid, and commercial prices. So PEB and OEB data are included in that commercial line for both of those reports. And hopefully those data will be coming out soon. And I think that's everything I had. Any other questions or comments?
Okay. Well, thank you, Sarah. Appreciate you coming back.
Thanks for having me.
Well, do we have any public comment that's come in? Or do we have one more thing to address?
There's no public comment.
Thank you, Rose. Margaret, anything else?
No, nothing else. There are a couple of other attachments that were included in the packet. Attachment 4A and 4B, which are just supporting the recommendations and some other supporting information that Sarah provided in terms of the timeline for the healthcare cost growth target program. So that's just information for you to refer to in terms of having a little bit more background context.
Okay.
But aside from that, I think we are ready to just summarize any final next steps and wrap.
Okay.
One topic I did want to note, just to mention, that we've had a little bit of preliminary discussion on in terms of planning for the February meeting and knowing what's coming down the pipeline. We did go over, we have a number of follow-up items we'll be working on related to the Center of Excellence RFI. Additionally, we're doing some work around performance guarantee approach as we look ahead to the upcoming contracts for OEB 2021-22 plan year, which will start October 1st, and the PEB 2022 plan year, which will start January 1st. We want to do some work to refine and further develop the performance guarantee approaches that are included in contracting. So that is a body of work that we'll be bringing to the innovation work group to start some discussion and talk about frameworks for that next month.
That's good. Keep us all on the same page.
Yes.
Okay. Any other comments from the group? So we will have a follow-up debrief in the meeting and work towards setting the agenda for the next meeting.
Yes, absolutely.
Okay. All right. Thank you all. Meeting's adjourned.
Thank you.